Welcome to this virtual curriculum for difficult neuro-ICU conversations. In this curriculum, which will be about 30 minutes in length, I'm going to present a specific conversation framework that we think is useful for holding these conversations. There's 3 parts here. The first part, which you're in currently, it will be where I present some principles of difficult conversations that are useful to know as you move through the second 2 parts, which introduce the conversation framework we'll be using, which is called the best case, worst case framework. And in the third module, you will see this framework applied to the neuro-ICU setting through a specific role play. So again, we're in the first module, which is an outline of principles of these difficult conversations. And to anchor our discussion, I'm presenting a clinical vignette that is fairly common to all of us. This is of a 71-year-old man who comes into the hospital after an at-home cardiac arrest. While he never had any seizures, no early myoclonus, and continues to have all of his brainstem reflexes, he has not shown any recovery of conscious activity after 1 week. He does have several cardiac risk factors, and his arrest occurred in the setting of an occluded coronary artery, which was revascularized. It is now about a week into his ICU stay, and you'll be leading a family meeting with his wife and children after rounds, as soon there will be a critical decision point whether to pursue a tracheostomy and a PEG or a different route of action. And during this conversation, you're going to have to guide the family through some specific questions. They may want to know how likely it is that the patient will survive. They may want to know what survival will look like. And then they'll have to answer for themselves what they think the patient would have wanted in this scenario. As we know, many patients don't really put down in writing what exactly they would have wanted, or the scenario does not perfectly match up with what they had placed in writing. Now I'm going to argue, and I think we all would agree with this, that the how we go about telling the family is just as important about the actual content we relay. We could just write down our answers to these questions on a piece of paper and give it to the family and ask them to deliberate and make a decision. That likely would not be very effective at all. Now, as we hold these conversations, there are several things we have to keep in mind, namely that there are several barriers to communicating these prognoses that exist between surrogate decision makers and the physicians. I'm going to present some data from a study conducted in 2016. These researchers surveyed physicians and surrogate decision makers who were caring for very sick ICU patients. These were not necessarily neurological ICU patients, but they were very sick on ventilators and had a very high chance of death prior to hospital discharge based on Apache scores. Now, this curve demonstrates that physicians were more accurate in their predictions of mortality than the surrogate decision makers. In this receiver operating characteristic curve, curves closer to the left are more accurate. Curves closer to this dotted diagonal line are less accurate. And if you were right on this line, it'd be like performing a coin flip in your predictive accuracy. Furthermore, there wasn't just a difference in accuracy. Surrogate decision makers were more optimistic in their prediction, which is what this figure from the paper demonstrates. The surrogates are in this orange line and generally gave a significantly higher chance of survival than the physicians. And you might be saying, this isn't too surprising. As physicians, we've gone through a lot of training. We have a knowledge that the surrogates don't have, so this would account for some of this difference, and that is true. But the researchers did account for this, and in doing a qualitative survey of the surrogate decision makers, were able to pull out some important underlying factors that also played into this difference in optimism. And they present some of these factors in this chart, which I've placed here. So surrogates often believe that the patients had unique strengths that the physicians did not know about, and that these strengths would help them pull through their crisis. Surrogates often also had to maintain hope for their own benefit, a hope that the patient would survive this. There were religious beliefs that often led to a more optimistic prediction. And then many surrogates believe that the physician was simply pessimistic by nature, and that this was clouding the physician's estimate of their loved one's ability to recover. So now, knowing that surrogate decision makers often have a more optimistic idea of survival in these critically ill patients, and that there are these specific factors underlying this this belief, and it's not just simply a knowledge gap, it sort of changes how we look at these important questions. And I would argue it makes the how question at the top, the how likely it is that the patient will survive, a bit less important than the what survival will look like. And I think in many of our conversations, we often focus too much on giving a number about the likelihood of survival instead of painting a good picture about what survival would even look like. Because that's going to be just as important when the family members decide what the patient would have wanted, knowing the what. Now, moving on to the second bullet point here. As neurologists, we're often placed in a difficult position here. We are given clinical scenarios where we have a hard time giving exact prognoses, and endpoints are often very elusive. It can be very difficult to tell patients and families what is going to be happening down the road in 3 months, in a year, in 2 years, when we're talking about these very severe brain injuries. But we still have to provide decision makers with good information they need as they make these really critical choices in the ICU. And that brings us back to our vignette. Now, we know that there's maybe some good signs here. There was no severe myoclonic status in the first 24 hours. He has always had his brainstem reflexes. It seems like his ICU stay has been pretty uncomplicated so far. And otherwise, he has some generic cardiac risk factors, but it doesn't seem like he's in heart failure. That seems to be okay. But again, it's been a week and really nothing at all has been happening. He's on the older side. So this does raise some concern. And I think in this scenario, it's going to be hard to give the family a firm answer about what he's going to look like, if he's going to wake up, and what the most likely scenario here is going to be. And this is something that often in the neurological population is a big cause of strife between surrogates and physicians. This study was done in critically ill traumatic brain injury patients, and the researchers surveyed surrogate decision makers and doctors about how they like to relay prognostic information. Surrogate decision makers strongly preferred that they were given hard numeric estimates of prognosis, and they found uncertainty very frustrating. This isn't too surprising. You can imagine that providing a number would help them anchor on something. They can make a decision based on that, or they could hold out hope if there was a high enough percentage that there might be some chance of recovery. Physicians, however, did not like to give those hard estimates. They felt that uncertainty was a part of how they were going to communicate prognosis. They felt that they could not use good prediction scores with individual patients, and they like to give more qualitative terms instead of a percentage. So that raises the question, if we often can't provide families with specific prognostic numbers, well then how else can we guide them to making good decisions? And that's where these conversation frameworks, I think, can be very useful. And this brings us back to our questions that I posed earlier, namely, how I think that the what survival will look like is more important necessarily than the how likely it will be that the patient will survive. And that's what the framework we're going to present in the next 2 modules tries to get at. This is called the best case, worst case framework. While it was originally designed for high mortality surgical decisions, it can also be used and is now being used in more medical critical care scenarios. And the way it works is that you give the choices on the table to the family, and you paint a very detailed picture about what those choices will look like for the patient and the family so that they can take this information without specific numbers and use that to make a good decision that is congruent with the patient's wishes. So for the second part, you're going to watch a short YouTube video showing how this works in the surgical world. And in the third part, we're going to see how this can be used in the neuro ICU setting with a short role play.